So we're going to talk about alcohol use disorder today, namely an overview of diagnosis and treatment. There we go. No disclosures. The objectives are to distinguish risky drinking from alcohol use disorder, learn how to properly manage withdrawal, and primarily we'll focus on the different pharmacologic approaches to decrease a chance of returning to heavy drinking, and then just touch upon briefly, probably not enough as warranted, but touch upon some non-pharmacologic methods for the treatment of AUD. So first we'll talk about how much is too much or too often. It's very, very common, so good to know these things. The standard drink in the US, so when we're asking people how many drinks, we just want to keep in mind that what they're reporting, 1 or 2 drinks, it may be different quantity, different percent alcohol, and so it's 0.6 fluid ounces or 14 grams of pure alcohol. And so, for instance, if someone's reporting, that they drink 4 beers in a day, you want to know, is that a 12 ounce, for instance, because that would be the standard drink size, and then you would adjust it based on the amount that they're actually drinking. This is just an example of a drink size calculator that can help you accurately quantify the number of standard drinks that someone has. So this is just an online one from the NIAAA that lets you enter information such as the alcohol content and container size, etc. So why does that matter? Quantifying risky drinking or assessing for risky drinking is based on the amount. And then we'll see that alcohol use disorder is based on different diagnostic criteria. So the National Institute of Alcohol Abuse and Alcoholism has defined the following quantities for low risk drinking, and this applies to non-pregnant adults. So for women, that would be no more than 3 drinks in a day and no more than 7 drinks in a week. So if they were having 2 drinks in a day daily, then that would exceed the weekly amount for low risk drinking. So that's why we ask about both the daily and weekly amount. And for men, no more than 4 drinks in a day, no more than 14 in 1 week. And that comes down to different metabolism rates for men and women. SBIRT is something I'm just going to touch upon. You probably are all aware of and hopefully have in your clinical settings. This has really good evidence. USPSTF has given it a grade B, so it's covered by Medicaid and Medicare. And this is to screen for unhealthy alcohol use in adults and then provide brief counseling interventions and referral to treatment. That's what it stands for if they are identified as having risky or hazardous drinking. Its evidence is strongest in primary care, but it can be administered in many settings. And it involves the 5 A's approach of asking about use, advising, assessing their readiness to decrease or stop drinking, assist and arrange for help with treatment. Sessions are brief. They last anywhere from 5 to 20 minutes. And the goal here is really to reduce the risk of the negative consequences of use and really help shift the amount before it does become a hazardous amount or meet criteria for a use disorder. And how do we screen for risky drinking? So starting with the single question approach, which is also similar to the screening for other substances. In this case, how many times in the past year have you had for men 5 or for women 4 or more drinks in a day? So that's exceeding that risky level. And if that results positive, then you would go ahead and assess the severity of their risk using a validated tool. We recommend the audit or the audit C as a simple 3-question one that you'll see here in the next slide in order to determine if they have a use disorder. There are more population-specific scales, so the MASS-G for geriatric populations and the CRAFT for adolescents. This is an example of how a patient may respond to that audit C. So if they responded yes, or they responded positive for that single question initial screen, then administering this one, you can see here, she reported having, how often do you have a drink containing alcohol? She reported having 4 more times a week. how many drinks containing alcohol do you have in a typical day? She reported 3 or 4. And how often do you have 6 or more drinks on one occasion? And then you can see there at the bottom that a score of at least 4 identifies 80%. 86% of men who would meet criteria for alcohol use disorder. And a score of over 2 identifies 84% of women. So this is a helpful tool to have at your fingertips. So for diagnosing, trying to remember if there's something else. I think this slide is missing that. There we go. For diagnosing alcohol use disorder, this is going to be based on the DSM-5 criteria. And basically, you can think of it, I'm not listing them all out here, but there are 11 criteria. Someone would report having if they had 2 to 3 of the criteria, mild use disorder, 4 to 5 moderate, and over 6 severe. I've always learned to think of it as the 3 C's. I'm sure there's other ways, but of those criteria, you've got cravings, and then different criteria that can be grouped into compulsions to use, and then consequences of use, whether that's social, medical, etc. And then the last 2 criteria are tolerance, so needing more to get the same effect, or withdrawal. So with that, once you have a diagnosis of alcohol use disorder, it's important to then move into treatment. And so just to talk briefly about what treatment rates look like in the US, it's not great. Only about 6.5% of adults and 5% of youth with a diagnosis of AUD in the past year received treatment. Less than 1 in 10 people in the US with a diagnosis of AUD receive treatment of any kind. 1.5% of people with AUD reported receiving an FDA-approved medication. Hopefully this will be increasing the next time we check it. And then as with other use disorders, we do see racial disparities, significantly racial ethnic minority disparities with getting barriers to mutual help groups and in general getting treatment, especially treatment utilization by women. So anytime we talk about treatment, it's good to consider both the acute and chronic management. So if you have a patient presenting to you in acute withdrawal, what are you going to do in that moment to help them through it? Because most of the time these are outpatient cases, and that's what we'll be talking about here. Certainly important to utilize our inpatient if possible when they meet criteria for that. But we'll talk a little bit about outpatient, and then we're namely going to focus on the next part, which is relapse prevention, which we can hopefully discuss from the initial visit, but sometimes once they stabilize and come back. So we'll talk about those FDA approved and some off-label but good evidence medications for decreasing use. So for the first part, just determining if someone has need for acute withdrawal management. We know, based on lots of evidence over time, that benzodiazepines are the mainstay of treatment, although we're definitely seeing more, and this probably, I should adjust this for the next time we present this, especially in our ER of treatment with medications such as phenobarb, but we have good evidence for benzodiazepines in the outpatient setting, and insufficient evidence for other medications to help prevent seizure, which is the main reason why we are actively managing people in acute withdrawal, preventing seizure and delirium tremens. There might be a role for gabapentin in mild withdrawal, but again, it's not to help prevent seizure. This is really small, but it's the CWA scale, which we use just in our initial assessment in the outpatient setting to make sure that someone actually is safe to have management at home rather than going into the hospital, because if they had a CWA that was certainly higher than 20, sometimes high teens with other risk factors, we would rather have them go through detox, at least initially, in a controlled supportive setting. But once we determine that we can give them an outpatient taper, this is just one example that I find pretty neat and easy to use, but there are others out there. This one's from the AAFP, and it's divided into a fixed schedule and symptom triggered schedule. We prescribe the fixed schedule for 5 to 7 days. Here's a 5-day course on this table. And usually we are prescribing the lorazepam, so you can see them split here into options diazepam, chlordiazepoxide, which are both nice long-acting ones, and lorazepam. We usually do lorazepam, especially if we don't have baseline liver function, just because it's not metabolized by the liver. And so if someone had significant liver disease or transaminitis, it'd be less likely to complicate that. And so for instance, if we were giving lorazepam, we would prescribe them 2 milligrams on day one. Every 6 to 8 hours, I would say we usually prescribe it for 6, but then move over to this column, day 2 every 8 hours, and then we decrease to 1 milligram every 8 hours, by day 4 every 12, and then 1 milligram at bedtime. Again, this is just one example of a potential taper. You'll see lots of variations on it. The caveat that we give people is that if they were to drink or feel sedated when it's time to take that next dose, they would not take the dose. So we don't want them to be oversedated or combine it with alcohol. Okay, so this is really the main focus of the talk, is how do we decrease a chance of returning to heavy drinking? So in that visit where we're helping people with the initial detox, we can be talking about this and possibly seeing them back by the end of that taper to introduce medication for relapse prevention. However, sometimes we can do that all in that visit if we're not, sure that they're going to be returning. Hopefully they will, but and then also if occasionally people present not needing acute detox management, and we can just initially go into this. But the main medications that we're going to talk about are okay if someone is continuing to drink. And so that's why we have this conversation from the get-go. I will say there was someone here today who one of the students clarified for them that, it's not all these medications, fortunately, act like the one that patients fear, the disulfiram, which is brand name Antabuse. And so sometimes people are hesitant to start these medications when they're drinking, but most of the time it's okay if they do. So this is really just a figure showing the complexity of the sort of anticipation, binge intoxication, withdrawal, negative effect parts of the cycle of alcohol use disorder. And I think that it's helpful to consider this because, unlike, let's say, opioid use disorder, where it's rather neat in that we have a particular receptor, the mu receptor, that we're targeting with our medication very directly, alcohol use disorder is a little more complex. And so this, I think, picture kind of represents that, which is part of the reason why it's sometimes really challenging to find the right treatment from the get-go. But I think the other reason why this is useful to consider is that I think there's a lot of opportunity for points where we can possibly target this cycle with medication and certainly with other therapeutic interventions as well. And maybe why there's also, a lot that could still be developed on the horizon to help treat alcohol use disorder. So the medications we will talk about in the next few slides, rather wordy slides, but I'll try to not bore you. The 3 FDA-approved medications are naltrexone, which comes in both a PO and extended release form, camprosate, and disulfiram. So we'll go into those. And then the off-label medications that are also recommended as second line, although we often use topiramate first line, are topiramate and gabapentin. And there's a few others, but these are the ones we're going to mainly focus on during this talk. So starting with naltrexone, this is our mainstay of treatment. Still, this was FDA approved first for opioid use disorder way back in the 80s, and then for alcohol use disorder in 1995. The extended release form, otherwise known as brand name Vivitrol, was approved in 2006. And it's pretty simple in terms of the dosing. It's just kind of straightforward, doesn't take much to get to that dose of 50 milligrams a day, once a day dosing. And the extended release doses just comes in the 380. I'll say just for prescribing purposes and counseling patients, we have people recommend starting on half a tablet a day just because of the potential for some GI side effects. And we don't want to lose the chance that they could benefit from this treatment because of that. So I usually prescribe it as the 50 milligram a day and just tell people to take half a day, but just for the first few days, and then they can increase it as tolerated. It is an opioid antagonist, which is why we cannot use this first-line medication for our folks who also have opioid use disorder and are currently either using or on medication for opioid use disorder. I'll touch upon that again at the end. But when taken for AUD, what it's doing is blocking the effects of endogenous opioids that are released by alcohol consumption. So essentially blunting or blocking that reward pathway in the brain. It is, again, contraindicated if someone's on opioids. We have occasionally seen this happen, and it is not fun for the patient when it will precipitate withdrawal. And so I would just say as a anecdote, I have seen it a couple times where someone, was on methadone with us, and methadone, of course, doesn't come up in the PMP, and they happened to get naltrexone from someone outside of our system, and they were thrown into withdrawal. So really important to counsel patients on this. We do recommend baseline and monitoring of liver function, but it's not a contraindication to starting it. If the liver, we used to be a little more hesitant about this, but in general, the rule of thumb was if liver function was 3 to 5 times above the upper limit of normal, and again, remembering that's different for men and women, then we would want to monitor it more closely and perhaps have to switch treatment. But usually, this is perfectly fine for most patients to be on. It can be started while someone is still drinking, and it's been shown really to decrease the chances if they have a drink while they're on it, that one drink would sort of turn into an extended relapse. So you can see the evidence there from big Cochrane reviews. So this is a very easy to prescribe, easy to take, generally well-tolerated medication for most people. So really want people to have this one at their fingertips. The last thing I'll say about naltrexone right now is that I do find that, I'm not sure what other folks think who have prescribed this, but that it has like a pretty dramatic, like, yes, that's helping me, or no, that didn't do anything for me for patients. It's rare to find people like kind of in the middle where you'd like kind of wonder if it's helping them or not. And so I think that's useful just in terms of like guiding treatment and deciding if they're going to continue on it or if you just want to kind of change course to something else. The combined study, this was the main one that we look at for naltrexone's benefit. This was the largest controlled pharmacotherapy clinical trial for treating AUD in the US, 11 sites. And this is really why it's recommended in primary care settings, just treat with naltrexone, because it was found that when they had these different arms of the study, really the naltrexone plus medical management, so just meeting with the clinician, had the most substantial decrease, as did placebo with medical management plus the intensive, I think it was 20 weeks of CBI in decreasing days drinking. So this was a very effective treatment for folks. The next one that is a little bit harder, I think, in terms of its seeing the benefit, but some people do very well on, and is our second FDA-approved med, is acamprosate. This is where it has a little more, I think, complicated sort of mechanism of action. It's an amino acid derivative, weak antagonist of NMDA receptors. And so with that, and inhibiting glutamate receptors, it can also alleviate some of the physical and psychological symptoms of withdrawal, but isn't meant for withdrawal management. It's meant for AUD management long term. The daily dose is a little weird. It's 3 big pills of our total dose of, 2 big pills would equal 666 milligrams 3 times a day. Taking that middle of the day dose can be hard for people. So if that's an issue, they can split it into 3 pills twice a day. This one is not metabolized by the liver, and it also doesn't antagonize the opioid receptor. So this can be helpful for a few reasons, like if someone either has OUD or they have significant liver disease, this would be perhaps a better option. And the most important role that we see in the studies seems to be preventing relapse in someone who's already been abstinent for at least 2 weeks. But this can also be taken if someone has alcohol in their system. And then disulfiram is the one that people kind of fear. We don't typically offer it, but we will prescribe it if someone's insisting on it or feels like they have to have this absolute approach to avoiding alcohol. It was approved long time ago. And its mechanism again inhibits aldehyde dehydrogenase and causes that awful disulfiram ethanol reaction, which is a constellation of those symptoms you see listed there. Does require liver function monitoring, and contraindicated in significant liver or cardiac disease. So we don't usually talk much about this one anymore, but just knowing that it is out there, and for some people, it may be sort of their mainstay of treatment, if they have to have that sort of absolute approach. And I would say that there's really not good evidence for it, but it's probably best if it's taken under supervision, best effect. And then this is the main off-label medication, topiramate. It's got lots of good evidence, lots of evidence coming out of the VA in particular. What it does is antagonizes glutamate and facilitates GABA. It shows in some 7 RCTs, more days abstinent, less frequency of binge drinking than placebo. I won't read all the wordiness on this slide, but basically has really good evidence. It is hard in that it has to be gradually increased to the target dose of 100 milligrams twice a day, and that's to try to avoid some pretty significant side effects that can occur. So we usually will increase by 25 milligrams a week, so that can take about 6 to 8 weeks. And those side effects are typically, the main ones are paresthesias, difficulty with concentration, kidney stones, and then also just be very careful if you're prescribing this to a woman of reproductive age. They have to be on really effective birth control because it is teratogenic. Gabapentin maybe doesn't have as much, it definitely doesn't have as much as topiramate evidence, but it can be helpful for some people, and is, I think particularly can be helpful if there's a big anxiety component to their drinking. And it showed an effect on the percentage of heavy drinking days. The target dose is 1,200 to 1,800 milligrams a day. And so that can sometimes also be a little hard to get to due to the sedation that gabapentin can cause some people. So we would have to gradually increase to that dose for most folks, unless they've tolerated it before. Has some potential for misuse. It is on the PMP now. And so good to just be aware of that and monitor for that. But again, this is not used for preventing seizures or DTs, but can help just with sort of the withdrawal severity, and then can be used also for relapse prevention as second line. Okay, so just to summarize again, the APA guidelines, naltrexone and acamprosate recommended for treatment of moderate to severe AUD, suggest topiramate and gabapentin for patients after first trying naltrexone or acamprosate. That is the APA guideline. I would say we are often offering topiramate in many cases before acamprosate, with patients being informed that it's off-label use. And then disulfiram should not be used as first-line treatment. Again, only if complete abstinence and they don't have any contraindications. And then just in terms of the last thing I'll touch upon with medications, this is a very busy slide. It's kind of meant to be, because there's a lot out there and there's not too much that's really neatly recommended at this point, but I think there's a lot of exciting stuff that's going to come out about it, I'm hoping, and will continue to evolve. This first article I put here about some potential for psychedelic treatment, so specifically this psilocybin study conducted by our very own Dr. Bott with Dr. Bogenschutz and others. This was a really cool study. Had 95 participants who were randomized to psilocybin and diphenhydramine or Benadryl in a 32-week double-blind period. And it showed heavy drinking days at 9.7% for the psilocybin group and 23.6% for the diphenhydramine group. And also showed mean daily alcohol consumption was lower in the psilocybin group. So exciting stuff there. And then, of course, everyone's talking about the GLP-1s, providers and patients alike. We kind of want to know more about it. This is basically just to say, this is a nice systematic review. I just put it here so you could reference it from the Lancet from just over a year ago that looked at a large group of participants, and basically showed the subgroup analysis. You can see there from 2 RCTs supporting data from 4 studies showed that the GLP-1 receptor agonist may reduce alcohol consumption, improve outcomes in some individuals. And we have more specific things. The review, breaks down. I won't go to it here for the purpose of time, but the specific things that were found with semaglutide, for instance, dulaglutide. So each of these was kind of very specific. Like, for instance, I think dulaglutide was looking particularly at patients who smoked and the decreased alcohol consumption. Others looking at obesity. So it's a lot of interesting data and not definite guidance yet in terms of us prescribing. And certainly we're not getting them approved. At least I haven't yet for treatment of alcohol use disorder. This is another nice one. This is kind of small and hard to see, but it was just from a couple months ago. This was a nice overview out of, I think, Sweden that looked at the clinical and preclinical effects of a lot of these medications. So just a nice one to peruse if you have particular interest in this. Okay, and then how do we decide which medications to take? So basically, we want to consider coexisting medical comorbidities. For instance, like we were talking about with liver and kidney disease, and certainly presence of OUD. Prior experiences with treatment really matter. So always asking people what worked before, as oftentimes it'll work again. Maybe what didn't work, so we don't go there if there was a negative effect. Considering the ability to take medication at a certain frequency, would someone potentially be find more benefit in like an extended release monthly injection? Considering psychiatric comorbidities as well. So remembering that we need to treat that, so that anxiety, even insomnia is a big one. All of these, if we don't treat those in conjunction with treating their AUD, it may be harder for them to avoid using alcohol. And so, especially if someone was like self-treating severe depression or PTSD. So we want to make sure that we're addressing those things. And just briefly to touch upon co-managing opioid use disorder and alcohol use disorder, kind of already talked about this before, but you would, because of that antagonism from naltrexone, you would not want that unless there are some cases where people have been off of opioids for a long time and would still meet criteria for opioid use disorder, but might get some benefit from being on naltrexone, because remember way back when it was approved for that, and actually for OUD, and the extended release form has some effectiveness. It's just that most of the time when people are continuing with OUD, if they're continuing to use or on medication for opioid use disorder, specifically buprenorphine or methadone, then you couldn't use naltrexone. So usually we're offering topiramate, again, off-label, but probably has better evidence than acamprosate and acamprosate. And then that second line one, gabapentin, would also be appropriate in many cases. And then just as to remember always when you're co-managing OUD, prescribing the naloxone to patients, and also I think this is shifted over time, but at least for a while, I think providers were often hesitant to continue prescribing buprenorphine if someone was actively drinking. And it's really important that people stay on their buprenorphine, and they just may need more frequent visits, engagement, and treatment to make sure that they're safely taking it, but and not sedated, et cetera. But I think we want to make sure that we're not withholding treatment from people if they have co-occurring AUDs. So I just wanted to mention that. And then this is just a very shamefully brief overview of some behavioral interventions for AUDs. So, but just to not neglect the importance of this, right? We talked a little bit about that brief intervention, that there's really good evidence that as far out as a year and more, I believe, up to 2 years, that this can lead to a reduction, 20 to 30% reduction in heavy drinking. And so, and this again can be just like anywhere between 5 to 20 minutes to spend with somebody. And so Remembering our SBIRT model. The motivational interviewing has a lot of evidence for many things, including a treatment of AUD, over 32 studies showing benefit for that. It was found to be most effective in the first 3 months and with younger populations who had occasional heavy drinking but low clinical dependence. And then remembering that mutual help, which does include AA groups, can be helpful for some individuals. I would say that this is, sometimes one of the hardest ones in terms of like finding the right group for someone. So just making sure that people are aware that if they go to one group and they like the idea of that in terms of therapeutic approach, but they feel discouraged because some groups may discourage medication, for instance, or maybe have a particular religious bent, that just letting people know that there's lots out there, some online models, some that are better for younger populations, et cetera. So I think having an active, ongoing conversation with people about the benefit of this is a good idea. And lastly, family involvement, when helpful, has been shown to reduce drinking in some trials. That can sometimes not be helpful, as you've probably experienced with some patients, but it's good to check in to see if that could be a supportive model for them. So in summary, please remember, we want to increase treatment. It's pretty low and causes significant morbidity and mortality in our country. We've got validated tools to screen for risky drinking, trying to help people early on, and also for diagnosing AUDs so that we can offer effective treatment promptly. We want to be able to assess their withdrawal risk and recognize if that can be safely done outpatient and be able to provide them with that if so, and then counsel patients about the different treatment modalities. And then we'll keep our eyes out for new meds wherever they may appear.